Okay, my name is Josh Falwell, and this is a quick presentation on ACL tears and recovery. So what does the ACL do? It is known as the anterior cruciate ligament. It's vital in stabilizing the knee. It has similar action and structure to the MCL, LCL, and PCL, which are also ligaments of the knee that are just located in different areas of the knee. Because the knee tends to move forward, especially during knee-related injuries, it's the most injured being the ACL, and it's the first to rupture when this occurs. So it's a ligament that connects the knee and makes sure that it stays stable when doing different turning motions, walking, different things like that, preventing the knee from sliding over the tibia or behind or anything like that. So who suffers? Who's most likely to get affected by an ACL tear? It's typically seen mostly in high school girls soccer, followed by boys football and boys basketball. Obviously, this affects all ages and all sports, not just these three, but these are the most popular or most frequently experienced ACL tears. Um, Girls actually tend to experience the ACL tear more frequently than boys due to the physiologic or anatomical makeup. Girls have wider hips and tend to bend the knee inward, which increases what's known as the Q angle. I'll talk about that later, and applies more stress on that ACL and other ligaments in the leg. Uh, there are ways for girls to adjust their stance or gait to prevent this, but when you're competing at a high level and your body is changing, like in high school, your hips are getting wider, and it's hard to anticipate or adjust for this and change your running form, for example, while you're in the middle of a season. So in soccer, which involves a lot of quick turns, um, and it's also semi-physical, you can imagine that girls will tend to tear the ACL or sprain the ACL and stuff more frequently. Boys football and boys basketball, I think, due to the body changing and then the high physicality and contact that's involved in these sports can cause a lot of injuries because we'll get into how these injuries occur later. So the Q angle, what it is, you take a line from a bone marker in your hip and you take it to a bone marker in your ankle and you cover that line you intersect that line with a different bone marker in your ankle to a bone marker in the hip, and you develop what's known as a Q angle. So by taking these different bone markers, intersecting your line, you can actually get a relative measure that describes or anticipates how kind of likely you are for an ACL tear. It's not exact, but by telling you have a higher Q angle or your hip is by having a higher Q angle, it's meaning your hip is wider or you're applying more stress. You can anticipate who is more likely to have an ACL tear than someone who has a smaller Q angle. So my next point is that this gives us an idea of the internal rotation by looking at the bone markers. Again, it's not really important for what the bone markers are. I mean, you'll have your Q angle taken by an exercise physiologist or a physical therapist, and they can tell you, okay, you're more likely for an ACL tear, maybe wear a brace or change how your gait is set up or something like that. And then my third is the larger the Q angle, the more pull is being applied to the quadricep muscle, which is increasing the risk for tearing your ACL. So again, we use this Q angle kind of to anticipate whether or not this tear might occur or who's more likely to have this tear occur. So what actually is causing the tear in the ACL? Um, it often occurs when the foot is planted in the ground and an external force is applied to the knee. A good example of this would be football. A running back is running. As he's making a cut, someone tackles him in the knee. This is very, very common. It happens all the time. And by applying that force to the side of the knee or in front of the knee, it's very likely that the knee will overextend and cause a tear in the ACL. It's also common when changing direction quickly or changing direction when the foot is stuck. So if you do a turning or a cutting motion, like I mentioned about in soccer and in basketball very frequently, if you're turning your body to catch a ball and turn and run at the same time, or you trip while you're turning, the ACL and the knee is likely to suffer from that motion and that high intensity that's occurring when that motion is applied. So the immediate outcome, what happens right away after you tear your ACL? So after experiencing the tear in the ACL, you must undergo a reconstruction of the ligament before any therapy can happen. The ACL does require surgery. It happens pretty right away. There's nothing that can stop it from happening. It can take 2 to 3 weeks or up to 4 to 6 weeks before you can walk following the surgery, and then up to 12 weeks before someone can walk briskly. Further reconstruction is needed. It can take longer. So sometimes whenever that ligament tears or rips, you can injure the bone, the actual bone of the patella or the knee, or some of the other structural components of the knee. Maybe you had a tear in the ACL and the MCL, or your meniscus was strained or something like that, and that requires further reconstruction by a surgeon. It can take even longer. The order of recovery. So the first step to recovering is reaching that full range of motion. This occurs within the first few weeks. And then after the 12-week period, exercise can begin, focused around that knee, the muscles involving the knee, and establishing functional movement, being able to do things like walk up a stair or walk without support or something like that before you start actually working on recovering your strength. And then recovery overall for the exercise prescription can take up to 8 to 9 months or longer, depending on the severity of the ACL tear. So, what to avoid with the ACL exercise? Initially, we're going to avoid weight bearing exercises. Like we said, we don't have the muscle developed on the leg. We're working on that range of motion. So, we're going to avoid that weight bearing exercise. We don't have the stability from our muscles that we've been used to our whole life. So, a lot of falls, re-injuries, reoccurrences, things can occur if we're not expecting the weakness that we probably have from the deconditioning in the muscles. My next point is that we want to focus on resistance seated exercises. So using things like a TheraBand or a leg extension, something that we can control the weight on and we can actually change and manipulate to the point where we can make sure we're not injuring ourselves and we're still improving strength. It's going to be a much, much lower intensity than we're used to, and it's going to feel weird because your left leg will be functioning perfectly fine, but the right leg will be deconditioned and weak. My last point is that deconditioning affects the quadriceps and hamstrings mostly because of the size of the muscle. So these muscles we're using every single day of our lives as we're walking around, and they're the largest muscles in our legs. Whenever we injure anything, not even just the ACL, pretty much anything that requires us to be using crutches or a wheelchair or bed rest, we see a lot of deconditioning and atrophy in these muscles. Once swelling goes away, so after the swelling is removed from the surgery and the knee starts to return to normal size, we can incorporate some weight-bearing leg compressions. This is also after you've recovered range of motion in the leg. Like I said, you can do some leg compression exercises like half squats, full squats, of course, body weight, leg press, or TheraBand extension. Here we're starting to incorporate some vertical components, moving up and down. We can even involve some horizontal, moving left to right. We want to be very careful to avoid that rotation exercises. Anything that can involve turning of that knee, that's a little too soon. We want to develop some strength in our leg, stuff that can support that knee and hold it in place as we turn. And then I add that we want to do some neurological exercises that involve even standing on one leg or sliding back and forth, maybe catching a ball while standing on one leg, something like that. After 3 to 4 weeks of not using a leg, it's almost like you have to learn to teach it to do stuff again. Simple movements that you've done many, many times, you have to do it again, and it feels very awkward. And neurological exercises are very important in reteaching that leg. So the order to progress, step one, this is kind of the overall progression. Begin on working on your range of motion, light weights. This is after you've recovered from your surgery. So after 2 to 3 weeks, maybe after a month, start working on your range of motion. Just doing leg extension, going through manual therapy with a physical therapist, light intensity, maybe lightly with a band just to stretch. And then two, progress slowly with low weights designed to increase your functional capacity. Now we're going to want to get back to the point where we're able to walk on our own in a normal gait, walk up a stair using a handrail, something like that. And then once we're up to about 60 to 80% of functional capacity, we're feeling better, we can begin doing some aerobic exercise like walking, swimming, low intensity biking. And then from there, we're going to, as tolerated, we're going to progress up. We're going to focus on improving the muscle, improving the strength in those leg muscles, and getting us back to the point where we were before. So that's basically the recovery and knowledge about the ACL. Hopefully, you guys learned something.